Hello, this is Kay Lambert from the National LGBT Health Education Center, a program of the Fenway Institute. We're pleased to have you with us today for this important webinar on PrEP at home and teleprep in the time of COVID-19. Presenting today's session are Dr. Kenneth Mayer and Julian Dormitzer, NP. The webinar will last approximately 1 hour, with the presentation lasting about 45 minutes, with about 10 minutes for Q&A at the end of the presentation. The National LGBT Health Education Center is a part of the Fenway Institute, the Research, Training, and Health Policy Division of Fenway Health, a federally qualified health center in Boston and one of the world's largest LGBT-focused health centers. Our mission is to provide educational programs, consulting, and resources to help care organizations to optimize their ability to provide accessible, high-quality, and cost-effective care to LGBTQIA+ and other sexual and gender minority people. If you haven't already done so, please join our mailing list so that you can hear about future webinars, trainings, publications, and resources. You can sign up on our website, which is linked here on this page. If you have technical questions, the best thing to do is to call Zoom technical support at 1-888-799-9666 and choose extension 2. You can also contact me, the webinar host, using the chat function, which is accessible at the bottom toolbar in your Zoom screen. Simply click the chat icon and type in your question. Alternatively, you can email us at lgbthealtheducation@fenwayhealth.org for less urgent questions. If you're having sound issues, check to see if your computer speakers are muted. If for whatever reason you can't listen to your computer speakers, navigate to the bottom of your tool screen, go to the far left, and click the arrow that's next to the phone or microphone icon. You can choose I will call in. Pick up your telephone and dial the phone number and put in the access code, and you should be able to listen that way. At the end of the webinar, please close the browser and an evaluation through SurveyMonkey will automatically open for you to complete. We really appreciate your feedback, and it helps us to improve our programs moving forward and also helps us to secure funding to provide future programs. Completing this evaluation is required if you would like to obtain continuing medical education or CEU credits with a certificate. Please note that you'll receive your CME and CEU certificate 1 to 2 weeks after you complete the evaluation, not immediately. We are offering continuing medical education credit through the American Academy of Family Physicians for this webinar. Credits are equivalent AMA Category 1 CME credits, which are largely accepted as CEU credits as well. Please check with your own licensing body to determine whether these credits are accepted by them. If you'd like to claim credit for this time, you'll be guided through the appropriate steps once you complete the evaluation. Within the next week, today's presentation will be archived and available for free CME and CEU credit in the Webinars on Demand section of our website. The slides will also be available as part of the webinar posting. Please refer anyone you think could benefit from hearing today's talk. I'd now like to introduce today's faculty who will be presenting this session. With us, we have Dr. Kenneth Mayer, who's the Medical Director and Co-Chair of the Fenway Institute, a Professor of Medicine at Harvard Medical School, a Professor of Global and Population Health at Harvard School of Public Health, Director of HIV Prevention and Research and an attending physician at Beth Israel Lahey Health, and an Adjunct Professor of Medicine and Community Health at Brown University. Also presenting is Julian Dormitzer, NP and MSN, who is the project manager for the Adolescent Trials Network at Fenway Health and also a primary care nurse practitioner at Fenway Health. Thank you both so much for joining us today. And Dr. Mayer, please take it away.
Thank you, Kay. Really nice to be with you today. Just going to transfer the control of the screen, and I think away we go. So today we're going to talk about PrEP in the time of COVID-19, which reminds me of a wonderful book that I recommend you all read if you haven't, Love in the Time of Cholera, about a different experience during a period of plague. We're living in exceptional times, and some of the things that started before COVID-19 are still practices we want to keep going, but we have to figure out how to deal with it in the middle of the pandemic. So in this era of social distancing, PrEP use may be less, but it's not zero. And as physical distancing regulations change over the next few months, one might expect to see more encounters that people might have where PrEP would be indicated. Something that Julian in particular is going to talk about a little later is the whole advent of telemedicine and how we can monitor people who are using PrEP with telemedicine. Um, and we don't think that PrEP necessarily requires these face-to-face visits. Ironically, I've been involved in a project for the last few years called PrEP at Home, and I'll tell you more about that. And another project that my collaborator, Aaron Siegler at Emory University, is doing with MSM in the South called ePrEP. And these were teleprep studies that already had been underway, and we have some experience to share with you about that. And then a good chunk of the talk is going to be Julian talking about the experience we have at Fenway with teleprep. So to talk about the issues and frame them, we recently completed a study looking at urban MSM, and it was mainly focused on peer navigation for HIV-infected MSM. But we also looked at PrEP practices among those participants in the study who tested negative. And if you look at the PrEP cascade in these 4 US cities, and the study was just completed within the last 2 years, although the majority of people had heard of PrEP, only about 1 in 6 had actually used it in the past year. And of those individuals, only about a little less than half had protected drug levels. So clearly, getting people on PrEP requires increased knowledge, but also working through these different steps of the cascade. We know that PrEP discontinuation is a substantial issue. So these data, looking at pharmacy data from around the country, Aaron Siegler found that PrEP persistence was really quite poor with high levels of discontinuation. So overall, the majority of people who start PrEP at 2 years don't continue. So certainly there are concerns about how we can maintain PrEP when we have less contact with patients. Another concept is the whole idea of why we might want to use remote PrEP. And there's some challenges for PrEP that remote issues, remote modalities will not solve. So insurance, medication challenges that people perceive, side effects, that's not going to be solved by remote visits. People's self-perception of risk or PrEP stigma and shame won't be resolved by that. But certainly we see that there are other factors that can be mitigated by home care. If people have other life events, they're too busy, transportation barriers, navigation of care, and stigma. And now we would add to that COVID-19, where it may be preferable for people not to come in for a clinic visit. In terms of thinking about the US, we actually have what Siegler and colleagues call PrEP deserts. So we know that there's a disproportionate AIDS epidemic in the southeastern US, and yet you can see there are places where the driving time exceeds 2 hours to be able to find a place that will provide PrEP. And this gets exacerbated, particularly when you're thinking about culturally, I don't know why I just did that, sorry. When you're trying to look for culturally competent services for MSM. So again, if you look at this map, you can see in the southeastern US, there's a hot spot where both the time to driving is particularly bad for MSM, and then providers who have services for uninsured MSM, another hotspot along the Gulf Coast, and certainly a lot of hot areas throughout. So the places where the PrEP need is the greatest may not be well suited in terms of the availability of PrEP for individuals. So the initial study that we did was in conjunction with Emory University and Bridge HIV, which is the San Francisco Health Department's research group. And so it was a 3-city study looking at home self-monitoring for PrEP. So the package that we developed was something that arrives to somebody's home like an Amazon box. It allows the individual to get throat, urine, and rectal specimens, to self-prick in for blood specimens, which can be tested for syphilis, can be tested for creatinine, and dried blood spots to monitor PrEP adherence, and gets sent back and gets reported to the clinician, and then medication is distributed. So the first part of the study was looking at acceptability of this process. We did a pilot and then asked people about their comfort. And you can see the green is, light green is agree, and dark green is strongly agree. can see that people in the pilot tended to feel confident about using PrEP at home package. They felt that others would learn about to use the system readily. They found it to be well integrated. They thought the system was easy to use, and they would like to use it regularly. And so really high level of acceptability. These data allowed us to go forward and get funding to do a larger study, which we're in the middle of at the present time, to actually test this the home PrEP monitoring versus standard of care. So again, this package, in the standard of care, people will tend to have PrEP initiated and follow-ups oftentimes 1 to 3 months. The PrEP at home system will allow for follow-ups, getting the kit from the lab, using the kit and returning it. The lab takes the results and then sends the results to providers. This can be done electronically or with paper copy, and then the PrEP prescription is distributed. So we're in the middle of the study, so I can't report efficacy data to you yet. The study is underway in Boston, Atlanta, Jackson, Mississippi, and St. Louis. Our target N is close to 400 participants. We're at 155 individuals who've been randomized, racially and ethnically, and in terms of age, it's a diverse sample. So far, our initial impressions are there's a lot of interest, there's good retention, but it's early days. And then we have COVID-19, and the challenge for COVID-19 is that it's a 2-to-1 randomization where a third of the individuals are randomized to standard PrEP, where they'd be coming into the clinic, and many of the clinics are closed at the present time. So the study is on pause, but there are some individuals who are starting remotely in the control group, but this is a small number. So we're hoping that as the pandemic comes under better control, we can resume the study to be able to provide definitive data about this issue. Then the other study that I'm not directly involved in, but is being conducted by my collaborator, Aaron Siegler, is being done in the South. And the other investigator there is Leandro Mena. So it's being conducted in North Carolina, Georgia, Alabama, and Mississippi. And this is a study focusing on young men who have sex with men. It's being conducted in the Adolescent Trials Network, the ATN. And this is not a randomized control study, it's a small demonstration project. And they've developed an app for ePrEP to help monitor people through all the stages of PrEP. So this is looking at the acceptability and feasibility of offering electronic PrEP monitoring for young MSM. So it includes telemedicine consultations, text messaging interface, some surveys for the research part of it, automatic reminders, and it can monitor people's progress. Anderson is a behavioral scientist that has a theory about what are the issues that take to motivate behavior change. And this schema shows for this particular project, the blue boxes with the EP are where the ePrEP intervention can act in terms of some of these barriers or facilitators. So the app doesn't do everything, but it covers a wide territory, and then it's supplemented by things like referrals through case management. This just gives you a sense of the screenshots of some of the different things where people can fill out the surveys, they can track that, they can track whether people have applied for the Gilead Drug Assistance Program, the calendar for when scheduled visits and follow-ups are due as well. And then each individual has a profile and has a opportunity for email, dedicated email, and two-way text messaging with the clinic site. So again, this study is in the middle of things. So this is, this and PrEP at home are portents of things to come that we hope. It's not, these are not the technologies immediately available today, but they're coming online hopefully soon as the studies complete. And the next steps for this study, the goal is to have 240 participants, and it's only in the early days of enrollment now. Young individuals wanting to make sure that there's a strong representation of young men of color and recruiting in rural areas. So it's trying to see if this can help young MSM move along the PrEP cascade in order to go from contemplating PrEP to initiating to staying on it and being adherent. So the last point I'd like to make before turning the podium over to Julian is for a number of these studies, when people are getting these labs done at home, we're using a commercial lab that is dedicated to doing these kind of home service public health work. It's called Molecular Testing Labs, and I put down the contact information for the person who's interested in public health projects. They've been able to do a variety of assays for us, and they're CLIA certified lab and can operate in most states in the US. They're based in Vancouver, Washington State, right across the river from Portland. So for PrEP in particular, we can test for HIV, creatinine, viral hepatitis, bacterial STIs, as well as tenofovir diphosphate. And they have a variety of instructions and protocols that people can do to collect these self-administered specimens. They also do other labs too, but we think that with this interest in telemedicine, mailing oneself up these kind of labs to avoid people having to come in for lab visits may be particularly useful. And with that, next to Julian.
Great, thanks, Ken. Let me give myself control back here. Okay, so as Ken said, my name is Julian. I'm a nurse practitioner in primary care here at Fenway. And I'm gonna talk a little bit about our quick migration to telehealth and what our PrEP care has looked like in this new delivery model. I'll be sharing some data about the numbers of patients we've seen and also share the steps we've set up to make this possible. So I want to point out that on April 8th, the CDC did issue some guidance on public health activities as they relate to the infectious diseases listed here on this slide. And one of the HIV priorities listed by the CDC in this COVID-19 context is both linkage to PEP and PrEP for persons at high risk for HIV, meaning new initiations, and maintenance of services for persons already enrolled in PrEP or on a course of PEP. So we feel strongly that these are services we can continue to offer in a telehealth model while some of this research that Ken just described is still pending. So this really covers these numbers are from March 23rd to about April 14th is when we've pulled these most recently. And during that time, our first three and a half weeks of telehealth, we had 16 new PrEP initiations. I'm sure this is higher even now as I talk to you all on the 29th, but this is what it looked like kind of out of the gate with us. 10 of these were conducted via telehealth with local lab collection, and I'll talk a little bit about what that looks like at our site. And we've conducted more than 200 PrEP follow-up visits. Again, this was between the 23rd and April 14th, so likely many more as of today. So PrEP initiation via telehealth for us looks very similar to what it looks like in the clinic. We assess for HIV risk using the current CDC guidelines discussing recent sexual activity, any recent bacterial STIs, unprotected anal sex in the last 6 months or so, and how often this person is using condoms with partners of unknown status or maybe positive status. And something that we've learned we really need to take into consideration at this time is not assuming that everyone's practicing the same social distancing. We've certainly had patients whose sexual activity has greatly decreased during this time, or maybe they've often had outside partners, but now they're quarantining at home or staying home with their primary partner, and so they're only having sex with one person. And we've had other patients who have reported many partners, 10, 15 partners during this period of social distancing. And so it's important to ask and not make assumptions about people's activity. I think it's really across the board at this point. PrEP initiation, we assess, of course, for subjective symptoms of acute HIV infection. And in the time of COVID, this can be a difficult conversation or a tricky clinical conversation because many of these symptoms are also symptoms of COVID-19 infection. So some key things to be thinking about are timeline, timeline of symptom onset as it may relate to a potential exposure. Most likely type of exposure, is this person a healthcare worker? Are they an essential worker and going in to work with the public on a regular basis? And maybe most importantly to think about what are the pulmonary manifestations. And we learn more about COVID infection every single day, and I certainly understand that not everybody has pulmonary manifestations, but if someone does, then clinically, obviously, we're more likely to think about COVID-19. and less likely to think about HIV. But this is a tricky component given what we're all living through right now, and I just wanted to point that out. So drug selection and adherence counseling is a piece we do via telehealth, very similar to how it's done in the clinic. Personally, I talk to patients about both Truvada and Descovy, use shared decision-making whenever possible about side effects and laboratory monitoring associated with each. This hasn't changed too much in the period of COVID. I'm having essentially similar conversations. They're just happening by phone or video. We counsel patients on the importance of daily adherence and perform, a 2 to 3 minute barrier assessment. And I ask patients, certainly at my PrEP follow-up visits, how has your daily life changed? If you used to tie it to an activity that was related to leaving the house and that activity isn't happening anymore, then, adherence could slip during this time. I think it's important to check in about motivation. If someone's having less sex or not having outside partners, how motivated are they to be taking PrEP right now? Do they need to be taking PrEP right now? And so those conversations may be different given what we're all experiencing. I've had several patients who have said, I have a daily routine, it's well established. I understand I'm not maybe at risk right now, but I don't want to break the habit knowing or hoping that things will open back up this summer. And so many patients are just continuing their PrEP use, but important to have specific adherence conversations that relate to social distancing, I think. And then, of course, discussing possible side effects or providing a number to call if patients do have any issues as it relates to PrEP initiation in this remote model. Our baseline lab work is very similar, the same to what we would do in clinic. And those are listed here. We are doing these tests at our local lab. So in our community health center, we have a lab on the first floor in our lobby. And although we're doing much, much less in-person clinic work, our lab has remained open. So we're lucky to have that resource here. COVID considerations for this are, our policy right now is we're not really equipped to be dealing with COVID-19 patients on site in terms of PPE. We don't have oxygen in our building, things that patients may need. We can't offer in the primary care model anyway. So we include a COVID symptom screen if we're sending patients into the lab to be sure we're not sending potentially symptomatic patients into our building. We encourage them to call ahead and schedule an appointment with the lab so that there isn't a kind of lineup outside the lab as we often saw pre-COVID-19. And we've also implemented a self-swabbing process at our local lab. Our lab here in our building is Quest Diagnostics. This isn't true of all Quest sites across the country. It's being implemented, I think, locally based on some advocacy happening by providers working directly with the Quest in your town or in your city. But our lab here on the first floor, to meet the needs of our patients, understanding we deliver a lot of sexual health as part of our primary care practice, has continued to offer these tests. So patients are being instructed on the best ways to self-collect rectal swabs, throat swabs, and actually we've just added vaginal self-swabbing as well. So what this looks like is patients come into the local lab. These tests would have been ordered by myself or another provider, and they're given an instruction sheet and a quick walkthrough by one of the lab techs. And then they go into a private bathroom and collect these on their own. For our pharmacy, pharmacies in the area are open. It may be better to prescribe to a pharmacy closer to where your patient's living if historically they've picked up near where they work. Obviously, limiting the amount of geographic distance someone needs to travel to pick up their prescription is important. There are many pharmacies also doing delivery. Our pharmacy is doing free delivery, and there may be pharmacies in your area offering the same service. And so we've utilized these pretty widely for our PrEP patients. PrEP maintenance via telehealth is also pretty similar. So the difference here is we are not requiring routine testing for all of our patients, all of our PrEP patients, and I'll describe what that's looked like a little bit. But for patients who are continuing to engage in high-risk sexual activity, meaning PrEP is still likely important and a necessary piece of their HIV prevention toolkit, but they're asymptomatic for a bacterial STI, we're continuing to refill PrEP without requiring 3-month follow-up. I'll talk a little more about the nuances clinically that we've come across, but it is something that our medical director has told our providers we should feel comfortable doing at this time, understanding the CDC again is really recommending that we prioritize the maintenance of HIV prevention care. So I'm always sure to counsel the patient that this is temporary. I think post-shutdown, we will be restricting and probably rein in our PrEP services a little bit, moving back to CDC recommendations about routine follow-up. But given the nature of the COVID shutdown, this is a temporary change we're making. I also encourage patients to return for STI testing once clinical care has resumed. And so I tell patients, if a month or 6 weeks from now things lift, I'm happy to put in orders and have them come in at that time. Also counseling patients on the importance of daily adherence, and similar to what I described in more detail with initiation, doing a barrier assessment about changes in adherence that may have occurred due to changes in their daily routine. And I know I just was talking about the fact that our lab is open, and our lab certainly is open, but we're making a concerted effort as providers to use that service carefully. You know, we really don't want all 35,000 of our primary care patients coming in for all of their routine follow-up. We're being careful about how we use those lab services. An example of when we would use those lab services is if a patient is symptomatic for an STI. So obviously, if we know if they have a known exposure or a partner notified them of a positive test, we would be able to either send in treatment or schedule them for treatment with one of our nurses if they required an injection. But if someone's symptomatic and unsure of what they might have, I would send orders to our lab, and that would be a case of having the patient come in and get that testing performed. So there's been some guidance sent out about how STD clinics and STI services should be provided across the country by HHS, and I have the link to that on a different slide. But they've really asked that STD clinics prioritize serving symptomatic patients or patients with a known exposure. So we've tried to mirror that in the model I just described. And then STI clinics that might be closed in your area are being encouraged to utilize phone triage to help manage symptoms in accordance with CDC guidance on April 6th. This is a letter that was issued by DHHS, and you can find it at the link here. This was circulated to our providers. One nice thing is the second page of this letter includes possible treatment methods that can be used that don't require an injection. So alternative treatments for gonorrhea and syphilis that they do recommend as being effective. So if you really truly can't find a way to get your patient treated, or you have a positive test result and then are unsure on how to act on treatment, they've issued some guidance about how to treat with oral antibiotics for all of the possible STIs. So I have two case presentations to kind of put what I've just described into practice. CB is a 46-year-old cisgender man who has sex with men. He's on the phone for a 20-minute telehealth visit requesting PrEP initiation. So this would be a new PrEP patient. He reports some increased anxiety, which he attributes to COVID-19. He had 10 months of prior lifetime PrEP experience, but most recently was taking PrEP 2 years ago. So hasn't been on PrEP for 2 years. Reporting increased HIV risk during quarantine, including condomless anal sex with 4 new partners of unknown status, most recently 6 days ago. Feeling well, no fever, no malaise, denies any signs or symptoms of a bacterial STI, and of note, he's unstably housed and meeting up with folks who are also unstably housed and kind of communally gathering during this time. So I completed an assessment for acute HIV. He did not report any of the symptoms that we would associate with an acute HIV infection. I counseled the patient that baseline testing is needed because given his recent risk, I would worry about prescribing PrEP to him without an HIV test. So I did send in testing to our local lab and let the patient know that he should anticipate being asked to self-collect specimens. He reported to me over the phone that he was willing to do that. And I did send a 30-day prescription to the pharmacy for Truvada, because at the same time of kind of rolling out some of this telehealth in recent months at Fenway, we started to pilot same-day PrEP. I know this is something that different regions around the country, different health centers and health systems have approached. We probably initiated this later than other sites, I think, but I thought that this candidate, given his risk, met the need for same-day PrEP as long as he had that testing ordered and was coming into the local lab. And again, didn't start him on 3 months of PrEP, but initially sent in the prescription, waited for test results to send in a refill. So with him, I scheduled a follow-up testing visit in 10 to 14 days to assess for side effects and talk a little bit about adherence. So I think this case, you can tell, is we ran this very similarly to how we would run in clinic PrEP initiation, the only difference being that delay in labs. You know, he's not able to go down and get his labs directly after speaking to me, but he was able to make his way to the local lab, did have testing done. His HIV test was negative, and so he's been able to continue PrEP and initiate it during this pandemic. The second case study is a PrEP continuation visit. JC is a 26-year-old cis MSM on the phone for his 20-minute follow-up. He has one long-term primary partner, reports 2 additional partners since his last follow-up visit in January. And during quarantine, his only partner has been his sexual partner, his primary partner. So the 2 additional partners were pre-COVID. He endorses 100% adherence, no missed doses within the last 12 months. And this is a patient who routinely has come in for his 3-month visits. You know, through our relationship, I trust that he's a good historian of his adherence, and he didn't have any concerns about missed doses. Denied signs and symptoms of acute HIV or a bacterial STI. So this was a patient that I decided to renew without the follow-up testing we would usually require. Given his high adherence, follow-up testing was not required. 3-month refill was sent to the pharmacy with a request to ship it directly to his home so that he didn't need to go out and travel. And he was encouraged to come in for lab testing when operations do return to normal, meaning, you know, our governor has kind of encouraged people that there are other businesses open, people may feel more comfortable using public transportation. All of those pieces that fit into people coming back into the clinic was something that I encourage this patient to watch out for, and hopes that maybe he can get in for testing before 3 months is up. I counseled him on the importance of daily adherence as he continues to be sexually active, and again, just kind of reinforced that this isn't a model we'll likely be continuing, and that this prescribing without needing follow-up testing is strictly due to COVID-19 and an attempt to reduce traffic in our lab and keep patients safe. That wraps it up. I'm sure there are likely some questions, but Kay, I'll let you kind of take that away.
Thanks so much to both of you for that excellent presentation. We do have time for questions. We already have some questions popping up in the chat and the Q&A. I'll read those aloud so that we have them on the recording for folks accessing this at a later time. So if you do have a question, please type it into the chat panel. If you can't see the chat, go to the bottom of your screen and select chat from the menu bar. You can also select Q&A. Either way is fine. I'll be looking at both of those. So we'll start from the top. A question here, what type of blood tests were completed in the Emory University study? Could you talk more about the testing technology?
Yeah, there are two kinds of blood tests that can be done. There's a finger prick and then dried blood spot. So that's just pricking the finger, putting it on filter paper. And there are a number of different things you can test for using that. That's particularly useful for checking tenofovir levels if you're monitoring that. It also can be used for syphilis testing. And then there's another technique where a small lancet in the finger, you milk the finger and there's like a mini capillary tube that sucks up the small amount of blood, and that's particularly good for the creatinine. But there, you know, the molecular testing folks or any CLIA certified commercial lab will have protocols for specimen collection. But you know, all these things are quite doable for individuals. And you know, similarly, we do the GCCT self-swabbing of the mucosal sites. There are videos even for people to you know, be able to see how others do it if that's helpful.
Thank you. Another question here. Someone asks, do you have any recommendations for specifically outreach education for PrEP during this time of social distancing and quarantine?
I mean, I think we don't want to stop community education. I mean, you know, if an individual's engaging in behavior that could put them at risk for HIV, we want them to be educated about PrEP and to know how to access it, because certainly it would be a tragedy that somebody became infected because of lack of access during the era of COVID-19.
Yeah, I think, you know, social media ads, there can be more affordable ways to do kind of Facebook ads, or I think some folks are spending a lot of time online right now, might be a way to reach people. And I think a lot of our local organizations, our community outreach and education teams have attempted to work with our local organizations and bars or restaurants, the places we would normally be flyering in person, and tried to join them in some of the activities they're putting online, whether it's a Zoom community meeting or I think there was a virtual dance party for one of our LGBT kind of nightclubs, and our team was able to join and put some information up about PrEP access. So any ways to collaborate virtually, I think people are getting more and more creative with each week, but those will be important things to look out for.
Thank you. Another question here, can you please comment on other at-risk population patients, such as folks who are IV drug users? Also, are there other blood tests that should be done prior to prescribing for the intravenous drug user patient population?
Yeah, because of the population who Fenway serves, there are not a lot of PrEP patients who are people who inject drugs, but certainly there are some. And I think messaging for people whose risk may be injection drug use is extremely important. And there are a number of local and national organizations that certainly do a lot of outreach in this regard. Locally for us, Boston Medical Center and Boston Healthcare for the Homeless have outreach and advocacy programs for people whose major risk for HIV is in drug injection, and they provide PrEP. In terms of the tests that need to be done or optimally would be done, one would definitely like to know hepatitis B immunization status and serology if that's not clear, and certainly testing for hepatitis C as indicated for people who may be exposed parenterally.
Thank you very much for that. Another question here, do you have knowledge of the home test kit cost? And is this an item that has been provided via grant funding?
Yeah, so two separate things, which is what I described to you for the home kit was one that we customized for a specific study. So that was paid for or is being paid for by the National Institutes of Health. So that is a research study, but we contract with molecular testing systems, and I don't have the cost of each test, immediately available, but they have, but they have a website. So if you go molecular testing systems, you should be able to, click on the different tests and determine what the costs are.
And a follow-up question to that, to the mention of the molecular testing labs in research studies, is Fenway planning to use this in clinical practice instead of Quest?
I certainly can't speak for our medical director. At the present time, I think the model is to use Quest and have people come in, but I know that these other approaches have been looked at. Julian, if you have any updates for that.
No, I don't know of any plans to use it in our primary care. I think largely because our current plan of who we have coming into our local lab and how that's structured in terms of appointment setting has been working fairly well. We're starting to look into using the molecular lab for some of our other research studies because we don't have research staff on site. So we're, I think expanding its use in the research context, but I haven't heard about any plans to use it in our primary care clinic.
Yeah, I should emphasize too that the reason why we're doing the PrEP at home study is to determine if it's at least as good as home self-monitoring. So that hasn't been fully established. I mean, I think we have good reason to think it would be because of the earlier pilot study, the data I showed you, that there seems to be a high level of acceptability. So we're quite optimistic that this is going to be a workable system. And because they're a CLIA lab, if any individual person on this call wanted to use them, that'd be feasible. But I think for a health center to make that move, I think there's also probably a desire for some additional data, which is hopefully hopefully what we'll be able to provide in this PrEP at home study and in the ePrEP study.
Thank you. The next question is, someone writes, here in New York City, we have an at-home HIV testing program. How would you address potential positive results at home?
If somebody tests positive for HIV when they're being home monitored?
Yes, I think the person might be getting at how would you sensitively address a positive result to help navigate a person, especially during COVID-19, because the person's probably going to need to come in for a follow-up test to confirm that positive result. And so from both an emotional standpoint and a medical standpoint, how would you address that potential positive results in a home testing setting?
Yeah, no, thanks for laying that out nicely, Kay, because I'm sure Julian has some responses too, but I think the important thing about having a home testing program or any of these programs is certainly thinking about worst case scenarios and having the infrastructure in place to be able to respond. So certainly we have, for the PrEP at home study, the ability to have a participant contact us in real time so that we can talk them through how to navigate the system and certainly work with them around the surprise that they may feel from testing positive at home. So I think it's having both the behavioral health and the clinical resources then to be able to immediately make it seamless triage for them.
Yeah, I think a little bit about how we would operationalize that here. We have a study, a different study that we didn't describe in detail with youth who have access to home testing. When I say youth, I think about folks 16 to 24 years old. And in consenting those young people and talking to them about their use of this home test kit, I'm pretty explicit in, it's a home test, it's a rapid test, I should say. So the result, I'm not sure about the test you have in New York City, but the result then is given to that person in real time, outside of a healthcare context. And ahead of those tests being delivered to them, I try to walk them through what their options will be pretty concretely, given that I'm talking about young people. But I say, if I were to test positive in my home, I could do a couple things. I could call a study representative or myself, a provider on the study. I could call my primary care provider. I could call a friend, and I just kind of talk them through what those conversations might look like and almost try to develop a plan without, inducing anxiety, but thinking concretely about what their next step might be so that if that were to ever happen, it's something they've at least thought about. And in our primary care context, we don't have folks actively doing that in our medical department, but if we did, I think what we would do is have them call our nursing line, which is a 24-hour line monitored by nurses. And in off hours, we have a nursing service who can answer those calls from our patients. And they would be immediately scheduled for a telehealth visit or an in-person visit in the next kind of clinical operating day. And I think I would leave that up to the patient. I think it's something that could be done via telehealth, depending on their mental health status around that result, obviously. But I found a lot of patients don't want to come in because of COVID-19. And so someone may say, no, I'd love to just talk to a provider by video and get my lab work done, and I think I'll feel better. And other people may say, I need to come into the clinic and talk to somebody. And I think given the gravity of that, we would offer both options to our patients and then do the same local lab testing I described, having them come in for their labs here and sending the order ahead of time. That piece would be pretty smooth.
Thank you both for that. The next question, someone writes, I worry about patients who will resist adherence to 3-month follow-up labs or appointments after the shutdown eases up. The person agrees that it's necessary to be flexible now, but what kind of patient education and outreach do you expect will be needed once we're back to quote unquote normal?
I think we have to individualize by patient and work with them around what are the perceived barriers to coming in the future. And I think we have to come from a harm reduction standpoint. We certainly want to be able to say them reasons why that they're not engaging may be problematic. But the more I think the goal of this ultimately, COVID-19 notwithstanding, is to be able to provide options so that for some people, if the barrier for PrEP initiation or PrEP persistence has to do with things that like coming in for visits, then the more we can mitigate that, the better. Other people, if, as a clinician, feel that they need the structure and the interaction and the support and the counseling of a face-to-face encounter, then you want to really try to push for that. But I think it's hard to have kind of rigid rules, and it's hard, it's the Yogi Berra, predictions are hard, especially about the future. So I think what'll happen, post COVID-19 is it's hard to know. I think our goal is to try to have good options during this period of time, since we don't know how long it may be lasting. Julian, do you have other thoughts about that?
No, I think it will be kind of patient by patient. I think they'll both be patients who say, well, you did this with me via video, 3 months ago, why are you making me come in now? And we'll have patients who say, I know they say it's safe now, but I still would prefer not to come into a clinic, given we don't have a vaccine or things like that. And I think that, there will be patient education that has to occur at that time. As much front work as you can do now in describing why we're doing things the way we're doing in this current phase, I think will help patients understand why that changes. But I think I would just continue to use language like, what you described for the last month, I'm really concerned and I just want to make sure we have all of our testing in place. Or, sometimes I just fall back on what my needs are as a provider for why follow-up testing might be required for safety and documentation purposes. So I think it'll be an interesting, 12 to 18 months, and will have to be handled patient by patient through careful conversation.
Thank you. The next question is, when do you anticipate these home testing kits will be available to the general public? Is there discussion of how those would be accessed? And do you know of home testing kit availability for basic HIV, STI screening, for example, gonorrhea, chlamydia, oral and anal swabs, urines, etc., that are accessible now for our patients who don't want to come into the clinic?
I know that these kits, and again, I mentioned molecular testing labs because that's who we're working with, but there are other CLIA certified labs, so they're not the only ones. So these are available now. It's in other words, they're available, and if it's CLIA certified, it should be reimbursable. But given the crazy health system we have in the U.S., the program you're using to pay for it, the state you're in, the person's insurance, all those things have to be sorted through, and so I wouldn't be in the position to give sort of a blanket answer. But the point is that the kit that we use for the study is all the same labs, and it's pre-packaged because we're doing a study, so we want to get the same measurements on everybody. But this is a commercial laboratory, and there are others, so they will mail out whatever the prescriber orders to the patient, so they have the ability, and it's the full STI panel. But if the clinician says I only need to be screening for gonorrhea, chlamydia, or I only need to be screening for syphilis, they can do that as well.
Thank you. The next question is, how can an HIV/ASO/CBO help to streamline a client in accessing PrEP when providers are limited or non-existent? Can a client use testing results from a CBO to verify HIV status? And also, can you provide tips on how to encourage primary care providers to offer PrEP? So there's a few questions in there.
Yeah, and they're very broad questions. They're important questions, but again, the local context is specific. There certainly are examples around the country of CBOs working with clinical sites. So I think it's a matter of fostering local partnerships, because certainly if the CBO is doing the testing under the aegis, say, of a state health department grant, CDC grant, they're certainly using verified tests, so the results should have standing. So certainly, I can speak for us that we certainly would use those data. Obviously, if it's a rapid test in particular, it would have to be confirmed with another test. But as an initial point of entry for somebody, that would be fine if it came from the outside, and the CBO certainly would have standing the same way it would be from another clinician's office. In terms of getting providers engaged in PrEP, I think it's a dialogue just to try to encourage them to feel that this is part of appropriate primary care. A colleague of ours, Doug Krakauer, has been doing studies for years, and it's still a barrier in some parts of the country. We know that, that some of the specialists, infectious disease specialists, think that it's too specialized for them, and primary care doctors don't feel that they either have the knowledge or the interest. And I think just trying to create community demand and and in the most appropriate way make the clinicians feel that they're not providing good primary care if they're not incorporating PrEP as part of that, I think is what we have to try to do. Julian, you have other thoughts?
The only thing I would add is leaning on some of these recommendations from HHS or CDC. If you are approaching providers at more clinical or medical institutions and you're a patient advocate or someone who works at a CBO, I think the guidance from kind of the federal bodies that monitor prevention is to continue this work at this time. And I think it's, for the reason exactly that Ken described, which is we don't want to see new infections in different areas after this time because people weren't able to access prevention services that we know work and have been working for several years now. So these guidances are, link was in one of our slides, and I think these slides will be sent out, but they're publicly available and may be an entry point when dealing with an institution that's a little more resistant right now.
Thank you both. And a comment here in the chat, we have some geography specific indications. So I want the kit, all one word.org provides 3 site mail-in CT/GC testings for residents of Maryland, Washington, DC, and Alaska. I want the kit also provides rapid OraQuick, but only for residents of Baltimore, Maryland. And then the person also provides, the Virginia State Health Department will provide free mail for OraQuick tests to residents of Virginia and Maryland. And then there's a link here that if you're able to access the chat, you can look at that link for folks in Virginia and Maryland. So I think that's a great comment. Thank you for that information. Our next question is a little bit about that geography specific piece. The person asks, the PrEP at home, is it only available in these areas or is it available on a national level? And who pays for the test kit? And where can you apply for this and request this moving forward?
Again, PrEP at home is a study, so it's not available widely. In other words, a study means that we don't know necessarily that it's as good as having people come in every 3 months. We think so, and the federal government thought that would make sense, and that's why they're supporting the study to be able to prove that. But the study is in the middle; we're mid-study, so we won't have the results probably for another 1.5 years or so to be able to say this definitively. But that's the study. The kits are available. There's more than one company, and I'm glad colleague mentioned I want the kit. The researcher there is Dr. Charlotte Gatos of Johns Hopkins University. So there are other places that offer other labs that offer kits for people. In terms of who pays, again, we have a very heterogeneous system. So in some settings, it may be that if you have a contract from your state health department, you may want to talk to them about trying to provide this for people. And then if it's a state grant, that would support that. In other settings, because this is a lab, CLIA is a lab certification program nationally, this lab is allowed to charge people for its services the same way that Quest would charge somebody for services. So this should be billable to insurance, but not every insurer is going to be as reasonable as others. So the reason why I'd love to give very simple direction, but we don't have sort of one system. So this is an approach that if it seems of interest, either contacting Molecular or contacting one of the other labs locally, asking around locally, are there labs that provide this? Molecular testing system is not the only one in the country that does this. So it's finding out who might be providing it in your neck of the woods, and then talking to them and finding out what experience have they already had with various insurers would be the way to go. But a lot of this is really doing the homework in terms of what kits do you want for which population, and how would they normally be paying for STI and other kinds of testing.
Thank you for that. Another question in a slightly different direction. Someone asks, is it reasonable to recommend apps or video for virtual sexual interactions as an alternative to in-person contact right now?
Yeah, no, it's a great question. You know, I think there are a number of considerations. Our colleagues at the AIDS Action Committee in Massachusetts have put out a Safer Sex in the Time of COVID-19 e-flyer. If you go to the National Center for LGBT Health Education, which is sponsoring this video conference, lgbthealtheducation.org. I think if you keyword, you'll be able to find the material. And that flyer mentions, remote kinds of sexual contact, people using videos, possibly even looking at pornography. And, this is a trade-off. For some people, this may not be fulfilling, and there's obviously concerns. On the other hand, really, because of intimate contact certainly can transmit COVID-19, we would want to recommend other ways of people finding sexual fulfillment that wouldn't put them in intimate contact with new partners at this point in time. That's just stands to reason. There are important things to keep in mind if individuals are doing this. Just still knowing who the partner is may be important, because one doesn't want to have a video kept as an archive of somebody in a compromising position. In terms of pornography, we have to make sure minors understand that there can be exploitation, and there are various rules in various settings for people who are younger age. So it's not a simple consideration, but I think in this day and age, we have to think about different ways that we can help our patients protect themselves.
Thank you very much. We've got about 3 minutes left, so we'll just take one more question and then start to wrap up. And it's a bit of a two-part question with some clarification. So the clarification question is, to clarify, we don't have to do an HIV test every 3 months and other tests before prescribing a new prescription for PrEP during a pandemic. That's the question. And then as a follow-up and add-on to that, what if the person is not using PrEP consistently and they accidentally begin taking it after they become HIV positive?
We want people to be tested every 3 months if at all possible. I think, again, it's a harm reduction issue, and this is where having the discussion with the patient, I think it becomes so critical. If there's any question that they may have had a lapse in terms of when they're taking PrEP and become exposed to HIV, we really would like them to be tested in that circumstance. And the question is how to get them tested. So I think it should be a communication. In other words, the message I hope that you don't take away from today is that in the setting of COVID-19, we don't have to worry about testing quarterly. No, we do, but there are times, I think what Julian was trying to say is there are times where we have to make exceptions because of the situation, but we wouldn't do it just blindly. We would do it in the context of somebody telling us that they're adherent and them understanding if they are misrepresenting that and they weren't adherent, that they have some risk. Clearly, if they become infected and they're taking PrEP, they have the risk of developing resistance to drugs that would be beneficial for them. So I think it's also explaining to them why it's so important to be monitored on a regular basis. But if they can't and if they're adherent, then the lesser two evils would be to provide them with PrEP if they're continuing to engage in risk, but they're being adherent to the medication. And now, Julian, if you want to add anything.
I think you covered all the highlights. It really is an individual conversation that I think a clinician needs to have with each patient, and doesn't mean that you'll as the clinician talking to the patient make the same decision in each case. But I think that our thought is being a little more open to the idea of deferring testing when appropriate at this time than we may have been 6 months ago, which we really would not have done that in any case.
Well, thank you both so very much. We're coming up to the end of our webinar here. For all of our participants, please note that this webinar has been recorded and it will be available on the National LGBT Health Education Center's website, where it's available for free CME credit. It'll probably go up within the next week or so, along with a link that'll give you access to these slides and the embedded URLs that our presenters were talking about. In the meantime, please remember to complete the evaluation for this webinar, which will automatically open when you close out of the session. This officially concludes today's webinar. Thank you so much to Dr. Mayer and to Julian for your time and for your expertise.